a few days ago, someone became quite upset with me and they left a comment saying, why can't you decide that which side you're on? Someday you're talking about vaccines and the other days you're talking about the side effects. Why aren't you on one side? And this is medicine. In medicine, when we do pharmacology, we talk about here is a drug or a molecule, here is how it works, here are the benefits of it, here are the side effects of it, and here is what happens if the poisoning occurs, and here is the antidote, here is when to not do it, here is when not to withdraw it. That is medicine. Medicine is not, here is a drug, here are all the benefits of it, and thank you, there is no side effect. Or here is a drug, and here are all the side effects, and there are no benefits. So the current discourse has become such that people expect grouping. And I want to be a medical doctor and talk medicine and not group.
Well, on that note, I just realized that people have joined us, and we are now at noon. Welcome, everyone. This is actually a very exciting day because this is the beginning of a series of webinars that I'll be hosting over the next years. They'll be intermittent to start. Actually, my favorite title for these is going to be called Educating Eric. And we're starting off with Dr. Mobeen Syed, who is one of the gentlemen who has done a lot of educating Eric over the last 2 years as COVID has descended upon us. And if you've been out there practicing or as just being a human being on the planet, you know that the information has been and continues to be exceedingly confusing. There's so many claims and counterclaims and some good science and lots of not so good science. And I have depended on Dr. Syed to help dig through the details and really do our best. And as he was just saying, this is nothing is black and white. I mean, this is medicine. This is about human beings. We don't know everything. So on that note, I just want to introduce Dr. Mobeen Syed. And I know him as, and many of you probably do, as Dr. Bean, who has dedicated your life to educating medical professionals and now people in general about medicine and just helping us sort through as best we can what appears to be true. And again, it appears to be true because life changes. So with that, welcome, Dr. Bean. I don't mind if I call you Dr. Bean. I got so used to that.
Thank you very much for having me. Dr. Bean is fine. Mobeen is fine. Syed is fine, whichever way you like. But thank you very much for having me. It is a great honor to sit down here and have a possibility to discuss some of these topics.
Yes, and the topics today are, just understanding. We're going to start with understanding long COVID, the pathophysiology and just some of the concepts behind it. Hopefully, we're going to plan a series of 3 of these where we'll go a little deeper into the pathophysiology of various organs and also treatments. But for today, I think just laying out the roadmap or the overview of long COVID.
Absolutely. I think this is a great topic. The only comment I'll make is that today is April 29, 2022. The information is changing. It's changing every day. And a study comes out today, and the next day there is a study that further progresses that. So we will probably continue to update it with Eric's schedule, but please take this information as so far true today, and what happens tomorrow or what more new arrives tomorrow, we will get an opportunity to come back and discuss.
Yeah. Oh, and I'd like to let people know who have joined us that I'll be reading the messages, and unfortunately, I am not a good typist, so we'll be probably keeping most of the replies to conversation as we continue. Okay, but if there's anything really important that we don't get to, we will reply later.
Excellent. And I want to just give a heads up as well that when I'm looking here, this is where Dr. Gordon is on Zoom, Eric is, and some chat is. So if I'm looking here, I'm really looking at this monitor. And when I'm looking here, I'm looking at my notes as well. So do not feel that I'm just randomly looking around. I have two monitors and I am using them while talking.
But like I say, it is the world of Zoom. Yes, we are
Yeah.
looking.
Yeah. Cool.
Okay.
So how do we start, Eric?
Well, I'd like to start, I think, just with what you have seen as the overview of long COVID. Are there any pre-existing conditions that seem to really make people more likely? And also just a comment, because it looks like the numbers, for a while people were talking about 25-30% of people, and I think that might be being dialed back a bit, or I don't know what your experience is.
Correct. So let me talk about this, and I have my studies open here as well. If you wanted, I could share them on the screen too. However, let me speak to them.
Okay.
So there is a few studies from UK that have shed some more light about long COVID and the symptoms and how long do they last. And then there are some studies that attempt to offer pathophysiology. So let's first start with the what is long COVID. And even the definition for long COVID continues to evolve. So the things to consider is that when we get COVID, it is possible that some of us have asymptomatic COVID, nothing happens and we become okay. Although even in the asymptomatic COVID, now long COVID is seen. But let's say there is a real mild form of the disease that we don't even have the symptoms. Then there is mild form where we have some symptoms, but we are at home and we can recover after a few weeks. And then there is moderate, where we are hospitalized and we may need oxygen and observation and so on. And then severe cases, and unfortunately, in some cases, death as well. The interesting thing is that long COVID is actually observed in all cohorts. And in the UK's number, they're saying that the population's 2.7%. Populations, not COVID cases, but population's 2.7% is long COVID at this time. And this is this month's data from UK. And if you take that data, I think it was about 1.2 or 1.5 million people. And then if you take that data and you use the COVID case count, then about 8% of the cases become long COVID. Now, these are outpatient cases. There is another study, which I have actually opened here as well. This is an American study from CDC. It is on the CDC site. They say that if there are patients who are severe, 2/3 of them become long COVID. But once again, if we go back to the definition, what is long COVID? Look, if somebody is severe, they might end up with cardiovascular system damage. They might end up with the respiratory system damage, correct? And the result can be that now they would have some months or years to recover from that. In some cases, they may not even be able to recover from the damage. For example, if the fibrosis has occurred in parts of the lung, or some parts of the lungs have become damaged and gone, they're gone.
They're gone.
Right? So that is also sometimes taken as long COVID, but that is not long COVID. That is COVID sequelae. That is the outcome of the COVID that has happened. Long COVID, in my opinion, is that specific situation where COVID occurred and resolved. However, there is something left in the body, either immune dysregulation or other pathologies, which then cause the patient to start having symptoms again, and those symptoms can continue for months and years. The definition, which is generally nowadays accepted, is symptoms beyond 4 weeks are being called long COVID. I have even seen long COVID where patients actually recover and they say, hey, I'm all good, I've recovered, celebrate, and all happy. And then a couple of weeks later, a month later, they start symptoms again. And this is the more dangerous part, because dangerous not in terms of the severity of the disease, dangerous because then if we are not educated about this, doctors, healthcare workers, we don't connect the dots that this was COVID's, outcome. And they think COVID was COVID, and a month later, the person had developed some other autoimmune disorder. And so it becomes difficult to connect the dots then. So I'm going to stop here to just, this is the introduction to long COVID. And please uh,
Yeah,
tell me how.
right. And what I was going to say is that I thought that was just very important. That's been my working definition as well. And someone has, was asking about, post-vaccine reactions, and in my clinical experience, I see the same thing in the unfortunate post-vaccine reactions, that sometimes they're 3, 4, 6 weeks later. But again, they're so clearly autoimmune responses in people who had no reason for this to suddenly pop.
Absolutely correct. And I have seen that as well. Even my own family members who got vaccine injured, they got the vaccine, had those immediate side effects,
Right.
Some lethargy or some joint pains and fever, and then became okay. And a month later, new set of symptoms appeared. And I can still not understand. They went to the doctor, and doctor said that she said that maybe this is vaccine related. And he said, no, nothing. This is just age related. And at this age, this happens. And this will not go away now. This would stay this way. And when it becomes worse, come back to me and I'll give you a Botox injection. And then I requested that we manage this as not long COVID, but vaccine injury. And with the blessing of God, now she is 99% recovered. If I go back to her doctor's approach, she must have been still suffering and thinking that this is part of her age.
Yes, no, that is the biggest issue, is that the refusal to realize that, these are immune responses that take time to develop. I mean, we are so, I don't want to make this about the vaccines, but the focus on immediate anaphylaxis is about the only thing that's considered a vaccine reaction is just disturbing. And again, you and I are both people who have been vaccinated and I fully support the vaccine for especially for older people. I think there's no question it is life-saving and has made a huge difference. But we all have to respect that there are risks to this. It's not a risk-free endeavor. And that's what I think has been lost in the discussion. But anyway, I want to stay on the topic.
You're absolutely correct. Yes. Okay, so that is the long COVID. Would you like to move forward with what is known so far for the at-risk?
Yes. Let's talk about that. And as I'm seeing, just to comment to some of the participants, is that yes, neurologic issues are a long COVID issue, and they are found, from the vaccine. Because I think one of the things we'll get to today is how important the immune system's response to the spike protein and to other part is a big part of what probably causes long COVID. And that's going to happen whether you got it from the infection or from the vaccine. So back to you. I want people to listen to you today.
No, absolutely. I think we both are able to move the discussion forward, and that is how this will happen. So I'm totally cool with that. And there are some questions here as well, as you were seeing them too. One clarification I would like to make is I usually separate the long COVID and vaccine injury from each other, not because they don't have overlapping symptoms. They're actually almost very similar to each other, but just for the definition of it, that long COVID, something after the COVID, vaccine injury, something after the vaccine.
Yeah.
But symptoms are, as you said, Eric, because it is spike protein initiated most of the time the problem, because most of the vaccines have spike protein in them as well. That is why their symptom sets are overlapping. And there was a question here that do you consider neurological symptoms in a similar bucket? So yes, the vaccine injury or long COVID, they have 9.1. So there is a study here where they did it for, I think, about a million people or 1.2 million people. And they saw that 9.1 on average, 9.1 organ systems were involved. We have 11 main organ systems. So almost all the body parts, all the body systems were involved in this disease. And almost more than 100 symptoms are seen. Majority of the symptoms that makes patient really um, almost disabled or have a quality of life deterioration are related to neurological issues. So that's a huge point, huge contributor to the long COVID related quality of life issues.
Yes, yes, because I just remind the nervous system really kind of modulates everything that happens in the body, and so yeah, so many symptoms that people attribute to the organ is often the nervous system affecting the organ.
Correct.
Okay.
So there was a question, Eric, that are there any risk factors? Yeah. And that is a very interesting part. Tell me this, have you seen any risk factors or kind of observed them in your patients?
I have to say, I've been disappointed by my predictive abilities. I would say people who have severe mast cell issues, or already severe inflammatory neurologic issues, make me very nervous for vaccine injuries. But but other than that, in the beginning, I was very hesitant to have my patients are mostly people with chronic fatigue and chronic Lyme disease and things of that sort and autoimmune diseases. And I was very concerned, but the level of fear was so high that they started getting the vaccines anyway, even though I thought maybe not, and they did well. So I kind of backed off and figured my predictive ability is poor, except for people with people who tended to have neurologic flares with inflammation. Those people, I feel strongly, the vaccine is not a good idea. I would rather deal with the COVID than with the vaccine in those people. I know that, but they're very rare, but and very difficult.
Got it. And allergies are generally also asked that patients stay away from vaccine. So this study here, this was one study that I have it open here, 1.2 million or so people. The other one is smaller. It is about 400 or 500 people. But in this study, the smaller study, it's also from UK. They said that the risk factors were, number one, females more than the males. So female gender is a risk factor. Younger age. This is very interesting. So the COVID's risk of killing is usually more with the advanced age or with comorbidities. COVID's risk of becoming long COVID is usually more with the younger ages. So every age has its own punishment, if you will, from this virus. It is just hard on everyone. So younger age, 39 to 53 age, or even younger than that. But in this study, this was the age range where they saw more long COVID. Then those patients who, when they looked at them at baseline and they had one organ system impairment, for example, they had kidney issues or they had cardiovascular issues or respiratory issues or pancreas issues, for example, diabetes or other such organs, if they had one organ system impairment, then their chance of having long COVID was greater. Yeah. Now, in addition to this, if somebody had severe COVID, then the 2/3 of the patients on severe COVID can have long COVID. And of course, I wanted to connect this, the female gender. This is my part, that's not the study. In my opinion, The reason is that females have a more developed immune system, a more aggressive immune system. And the reason for that is that female have two XX chromosomes and men have XY. And the X chromosome has a lot of immune system related genes on it and a lot of immune regulatory genes on it. So men, maybe they lucked out that they have lesser genes. For example, females may have up to 898 genes on the X chromosomes, and the man's Y chromosome, I think, has 50 or 60.
Right.
So there's a huge difference. So women have a double dose of immune system genes operations because both X are working. And that is why their immune system is more aggressive, which then allows the long COVID to take hold because it is really at the end of the day immune related.
Yeah. Yeah. This is a definite issue with men and women. I mean, men are simpler on all levels. I mean, even when we do metabolomic studies, we find that women, it will take many more chemicals to predict a disease than men. I mean, we're just not as complex as women. And just one of the things, I'm looking at some of these questions that people are asking. I just an aside, if someone has had 2 vaccines and they've had a significant reaction to one of those to the second vaccine, I personally think a booster is wrong. I don't say that, I don't like to be that strong, but I think the risk benefit for a booster, it does not add up if you've had a severe reaction to the second vaccine. I mean, it just
actually, they already say that if you have a severe reaction, then do not go for any further
right.
vaccinations.
Well, I mean, even anything, if you have anything more than fatigue for 2 or 3 days, I don't think, again, because you're not getting much increased protection. You're already fairly certain that you're not going to die. So step back.
Correct.
Don't go for perfection.
Agreed. And in the risk factors, I missed one. I just looked at my notes. Obesity
Yes.
is an equal risk factor with uh, as equal as having a female gender. So that means somebody who's obese, and we know that someone who's obese, they have hormonal dysregulation. They also have propensity towards diabetes. They also have inflammatory state all the time because of the fat cells producing that state. So all of those collectively just make the obese person's immune system almost as aggressive and as active or overactive as sometimes women have. And that puts obesity in the same bracket.
Yeah, yeah, yeah. It's the yeah, immune dysregulation, and I just think that the general, most people with obesity have some elements of insulin resistance, which I think just changes your whole metabolism. And gets us into trouble. But I just realized time, we can go, I want to make sure that we cover some of the important things, like some of the underlying concepts that we think may be behind or underneath long COVID and vaccine reaction. And I see people are already asking us about Dr. Patterson's work, and I just want to make sure we have time to touch upon those things.
Absolutely. So just lead me to the direction and we'll go there. So let's talk about the pathologies.
Yeah.
So there are multiple theories, there are researches, there are studies, and there is more evolution, there is more studies coming in as well. So I'm going to present what we know so far. And that also will not be holistic because I'm not able to read all the studies. So there may be some other papers out there that I've not read. There, not just maybe, there are for sure. So let me start from what I know. First of all, I want to start from the Neil Jenkins theory, which is called network hypothesis. Network hypothesis is that when we have a antigen in our body, something from outside, a virus, a bacteria, fungus, a allergen, something that comes in our body, and we make antibodies against it. Our body then has the duty of clearing these antibodies that we made. So that would be called homeostasis, that we want to go back to our normalcy. Now, for homeostasis, our body has many mechanisms to eliminate these antibodies that we made. For example, number one, these antibodies would degrade and deteriorate and finish almost in 3 to 6 weeks anyways. That's one. But the cells, the B cells that are making them, they would persist. Some of them would become memory cells. Our body's job is to kill them away as well once body is comfortable that there is no further antigen. And so apoptosis is a process where a cell dies silently without causing inflammation because that cell's role is done. It is just gracefully going away now. So apoptosis of the cells is another mechanism. Neil had another hypothesis, and that is that as we make antibodies, our body makes antibody to this antibody. So antibody to clear this antibody out. So spike protein came in, virus came in, we made antibodies to clear that out. Now these antibodies are running around. We made another antibody against this antibody to clear this out. And now they both kind of clear each other out and they go away and we achieve homeostasis. Now, in some cases, this clearance does not happen correctly and the B cells stay active and available. So now imagine, so this is the delicate part of this whole discussion. This antibody that was made, which is also called anti-idiotypical antibody.
Yes.
That antibody has to look like the antigen to be cleared by the other antibody or to clear the antibody. So let me back up for a second. If spike protein and the antibody bind with each other, then you remove the spike protein and you want to bind another antibody to this antibody. Guess what this other antibody is going to look like? It's going to look like spike protein, right? So not the whole spike protein, but parts of it, but still it is going to look like the enemy, and that is how they'll bind. This anti-idiotypical antibody can then in turn go and bind to ACE2 receptors and cause the pathology that spike was supposed to cause. Because now we are making this, and the problem is we are making it now. And if you're making it, we might continue to make it for some time. So that is called the network hypothesis. This explains a lot of problems. For example, cardiovascular system problem where the heart gets inflammation. Most of that inflammation is not necessarily spike proteins going and damaging it. Spike proteins can do it, but it is our autoimmune system. It's our immune system attacking the heart as well. Now that could be because of the molecular mimicry, which we can discuss separately, and that can be because of the antibodies as well. That can also be because of the inflammatory markers that are running around, and that can be because of the virus and the spike protein, meaning there can be multiple reasons for the cardiovascular system to get in trouble. If you go to the vascular system, for example, in the vascular system, if you look at the network hypothesis, what do we have more now? We have antibodies, and the antibodies are binding with each other, and they're binding with spike protein if present. And these complexes of antibodies are going to settle down on the vascular surfaces. And we know this. This is the type 3 hypersensitivity reaction, and that causes vasculitis as well. And when that vasculitis would occur, we will have vascular problems. And we are seeing the vascular problems affecting the brain and the internal ear and so on, the body, the COVID toes. In addition to the vascular problems, if you cause inflammation and inflammatory markers within the vessel, we can get clotting as well. And in the case of COVID, interestingly, the vaccine-generated antibodies can actually bind with the platelet factor 4. That was a study that came out of Germany after the vaccines-related clotting started. So platelet factor 4 can be bound with the antibodies, which in turn would cause local inflammation. Plus, that would also cause local platelet activation. and the result is clotting. So, network hypothesis can actually explain inflammation of the heart, inflammation of the blood vessels, clotting mechanisms, and more autoimmune issues.
And do you, one of the questions here, and one of the things that interests me, in the beginning there was a flurry of that, a lot of people with long COVID supposedly were improving with vaccines. Now that has
Correct.
not been my experience, but it does happen sometimes. Could
Right.
this be contributing to that?
So
That positive
absolutely.
response?
Yes. So now, absolutely. If you, and this only happens in some,
In
not
some, yeah,
everyone.
that's the problem. This is
Right.
not a
Right.
guaranteed fix at all.
Correct. Correct. And that means that they may be able to go do anti-ACE2 antibodies. So there's a company, and I have whatever companies I would name, excuse me, I have no commercial or any other kind of interest with them. I keep myself very clean from these relationships just so that I can teach. So there's a company called Inceldia. Sorry, not Inceldia, that's Bruce Peterson's. There is a company that that is German based. That company is Cell Trends.
Right.
I think it is celltrends.de.
Yeah.
Cell Trends does an antibody profile in which they do anti-ACE2 antibodies. Now,
Yes.
anti-ACE2 antibodies are going to be this network hypothesis based anti-idiotypical antibodies. Now, if somebody has those kind of antibodies, that means they may have the antibodies to the spike protein and the antibodies against these antibodies to spike protein running around in the body. In such cases, when you give vaccine would generate the anti-spike antibodies, which will bind with the anti-idiotypical antibody and clear them out. And it is also possible that the vaccine would help regulatory T cells to become active to kind of calm down the immune system, because vaccine is going to cause inflammation. The result of the inflammation is activation of regulatory cell as well. And that would calm down the system, in which the previous inflammation that was going on might calm down as well. So this is the mechanism for some of the people feeling better after getting another dose of vaccine. So if I continue with the pathophysiology, and there was I saw a question here which was very interesting. It
Yeah, there's been
probably
a few.
escaped me.
I'm trying to take notes so we can make sure we get back to them.
Yeah.
But
So, all right, I'm going to continue,
yeah,
and it's just I cannot
I guess
catch.
we can just throw out for the people that
Yes,
absolutely histamine, mast cell sensitivity can definitely be a part of long COVID for many people.
correct, absolutely.
And we'll
So
talk about,
now,
and we'll get to that in probably our third webinar in detail.
correct. So network hypothesis is one possibility. Then there is the, as Eric just talked about, mast cell activation, and that can cause these long COVID-like symptoms as well. And as we know from allergies, mast cell-like activation doesn't happen in everyone, but about 20% of the population could have mast cells that are overactive. In addition to this, or overactive or incorrectly active.
Right.
In addition to this, there can be macrophage activation. Then we also know the study from Dr. Bruce Patterson that there can be S1 piece of the spike protein hanging around in the monocytes, and especially the non-classical monocytes. And let me just very quickly explain that. If Eric, is that okay? Do we have time?
Yes, please. I
Okay.
think that is probably one of the most crucial things for people to understand, because I have gotten a lot of sort of clinical mileage out of using that
Mhm.
model.
Okay, got it. So let me explain this.
Yeah.
In our body, from the bone marrow, we make monocytes, white blood cells, immune related. These monocytes enter the blood circulation and they are moving around. Finally, some of them will get out of the blood vessel and go into the tissue and become resident there, and they can live there for years. These are called macrophages and dendritic cells. Now, monocytes come in three flavors. or you can say they can be in one of the three states. This is just like us. We can be happy, we can be upset, we can be neutral. Monocytes can be in these three states as well. They can be pro-inflammatory, they can be anti-inflammatory, or they can be none. So what happens is when the monocyte is circulating in the blood, they are usually in a neutral state, and we call it an intermediate state. Intermediate state is where they do nothing. When monocytes come out of the blood vessel, some of the monocytes actually just stay around the blood vessel. They become the guards that are at the tissue boundaries. And blood vessel to tissue is a boundary as well. So they would just continue to home in there and just march there. They're like guards. These are called non-classical monocytes. They are anti-inflammatory. That means they usually take part in inflammation resolution, in reducing the inflammation, in controlling the inflammation, in controlling the disease and bringing us towards health. These are called non-classical monocytes, because classical are those that we found out first, and those were pro-inflammatory. So the third type then is the pro-inflammatory monocytes, or classical monocytes. Classical monocytes are those that are going to go into the tissues and become macrophages as well, or dendritic cell as well. Classical monocytes' function is to phagocytose something, or pick up some antigen, something bad that came into us from outside, and then destroy it, remove it, and in that process start the inflammatory process as well. Non-classical monocytes' job is kind of a regulatory mechanism, just like on the adaptive side, Eric, we know that we have T regulatory cells whose job is to calm down the immune system and say, all right, enough is enough, stop, enough war. On the innate side, monocytes have this non-classical state where they can start resolving and reducing the inflammation. Now, Dr. Bruce Patterson's research has been that the non-classical monocytes that are patrolling the blood vessel boundaries, he found S1 to be present in them. Why is S1 in there? How long would it stay there? What is the mechanism for these monocytes to then become long living? Are all speculations at this time. His proof is that I saw S1 in the monocytes. Now, when the non-classical monocytes get S1 in them, and they're not able to get rid of them, normally what will happen is that when there is a antigen inside a cell, like monocyte or phagocyte, they would digest that antigen and destroy it and remove it. But if they're not able to destroy it, then they would start becoming inflammatory, and they would start releasing inflammatory markers. This is just like this, that if we have something stuck on our body and we're trying to get rid of it and it's not going away, let's say a cat, I have 2 cats, so let's blame the cats, right? So it is stuck and we are becoming all frustrated and upset. That is what a non-classical monocyte in Dr. Patterson's theory starts doing. And it causes inflammation. Now check this out. Where does that inflammation occur? At the tissue boundaries with blood vessels. So what would happen is local inflammation with blood vessels would occur, which would cause the vessel to have vasculitis. With that, the congestion would occur because fluids would start oozing out. The local hemodynamics will become unstable. Now, if that happens in the brain, we'll get brain tissue involvement. That happens somewhere else in the body, we'll get that tissue's involvement. So this is the theory of S1 sitting in the monocytes. The question that is still open is that a monocyte is supposed to die, I think, in a few days, 7 days or 14 days. Why is that monocyte living on for 15 months? So I have my own conjecture, and that is possibly the monocyte is not living on for 15 months. It is the job of the monocytes to clear other monocytes, or a macrophage to clear other macrophages or other cells. We have our own system of recycling our cells. And so it is possible that when one monocyte is dying and the other monocyte clears it out, that other monocyte might get the S1 transferred to it. And the S1 itself is not breaking down. So it's just going as a inherited piece of gold from one monocyte to the next to the next.
Uh, okay. I hadn't thought of it that way, but I like that. I was just thinking simpler, that the fact that the monocyte usually would digest that protein, and when anytime it isn't able to do that, perhaps it triggers a little bit of an immortality program. Because one of the things we see in the immune system is that the immune system, when it works well, it kills things, and you quickly have resolution of that local inflammation. I mean, what I call, what Dr. Navio calls the healing cycle. You go in there, the neutrophils come in, but if you don't shut off that system within 1 or 2 or 3 days, you start winding up with chronic inflammation, and that gets us into trouble. And so there's signals that seem to get to not work well in anybody who stays chronically ill. Our system works really well in acute illness, but acute illness that doesn't get turned off, then we're just learning rules.
Yep, you are absolutely correct. And monocytes can turn off their apoptotic signals if they are actively taking part in a war. So you are very correct that if S1 is not digested and the monocyte realizes that I have something with within my phagocyte and I'm not able to break it down, they might turn off their apoptotic signals and just keep living on.
Yeah. Resolution of inflammation is the key to healing. The question is, how to get there.
Correct. And then in the similar ways, if you keep seeing more theories, there is this theory from Dr. Racia Pretorius, where she's saying that the blood cells and the antibodies are sitting around and they're making clots and they're making complexes. Then there is another study which I had discussed about a year ago, where they saw that at least for 3 months after the COVID, blood cell structure had become distorted. So they called it cellular dysmorphia, that the shape, morph is the shape, dysmorphia is the irregularity of the shape. So the cells had irregular shape. Because of that irregular shape, they were not able to function correctly, because the cell's shape is an important part of their function. And secondly, they were not able to go through the blood vessels correctly, because they were irregular in shape and they would get stuck in the blood vessels, causing clotting-like issues because there would be a blockade.
And this is mostly the red blood cells?
Correct. And actually they saw other cells as well, but primarily red blood cells. They saw platelets in dysmorphic state as well.
That would make sense. Can you go into a little deeper into let me just put it this way, is that I've been playing with with patients with chronic fatigue, and I say play because it's a dance. I don't have answers all the time with chronic fatigue since the 1990 or so, and even in the 80s, but I really didn't know what I was. But the thing I've learned is that there's been all the stories that people have come up with, all the explanations, I think are accurate for some subsets of people, or they're all happening, but with with different weights to them. In some people, one process is the larger process, and I have a feeling we're going to have the same thing with long COVID. Is that I don't think any of these models are right or wrong. I just think it's a question of in whom that issue is less well controlled by their particular environmental and genetic backgrounds. So that's why I would like to go back, because Dr. Pretorius, just I thought, because I do see the D dimer go up even in, I mean, again, my own personal experience. I had a super mild case of COVID, like, I don't know, 6, 8 weeks ago. And I did my
mm,
IV
mm,
vitamin C thing, and I had almost no symptoms. 2 hours, I felt
mm,
crappy.
mm,
10
mm.
days later, my D dimer was 1.6.
Wow.
you
Mm,
know okay, and the reason I did it is because I had a patient back in the very beginning of COVID. Well, not in the beginning of COVID,
mm,
because we didn't all my
mm,
patients went to ground. I didn't see any
mm,
COVID for almost the first
mm,
year
mm,
because my patient just isolated. But I had one guy who
mm,
traveled in December of
mm,
2020. Anyway,
mm, mm,
asymptomatic, his D dimer and ferritins were through the roof. And I
mm,
think everybody becomes hypercoagulable. I don't care if they have no
mm,
symptoms, you know.
mm,
And that's
mm.
why I think there's a lot of vascular, I'm not sure how many of strokes and things really may be happening that we're not aware
Mm.
of. But I'm sorry, that was a little digression. But I just want to go back and love to hear your take on Dr. Pretorius's work.
So before I go to Dr. Pretorius's work, I wanted to add two, three more mechanisms,
Good.
if that is okay.
Oh, please, please.
Yeah. So because that in itself would start taking some time, and I want to package up the reasons that we know so far.
Okay.
So then there is another reason, and that is some people develop anosmia. Actually, it is becoming more common with Omicron.
Right.
And there is a study from UK that said that patients who had anosmia, after even a year, they had issues, the symptoms of cognitive decline. And they started doing their MRIs to see what's going on in the brain. And Eric, this is amazing that they saw the global brain size reduced.
Wow.
The whole brain size reduced. And the question then became, why did that happen? And their theory is that because olfactory nerve is connected with the majority of the brain tissues, the reason for that is that olfaction or sense of smell is part of us being at the lower animal level. And if you see, animals work with their smell a lot.
It's
Their
primary.
mating,
Yeah. Yeah.
right? Their mating
It's the first
behavior is with
sense.
smell. Correct. Correct. Right? Mating behavior with the olfaction. Their eating behaviors is with olfaction. When we eat, the sense of smell is an important part because smell and taste together make flavor. And we like flavors. If you take the sense of smell away, whatever we are eating, it seems like mush. It seems like we're eating nothing. So sense of smell is very important. In addition to that, sense of smell internally is connected with our emotional system. Of course, mating behavior is a very emotional system. So it is sense of smell is or olfactory nerve is connected into limbic system.
Yep.
It is connected with memory system. It is connected with auditory system. It is connected with visual system. For example, you could hear about a food and feel the smell, or you could see a fruit and feel this smell and olfaction. So it is connected almost everywhere. And the result of that is that when olfactory nerve doesn't fire correctly, we start getting disuse, atrophy of the brain tissues.
Wow.
And you would think that if the sense of smell is not working correctly, then it should not cause huge disuse, atrophy. It's just one little tiny sense. But it turns out that the global size reduction occurs.
Yeah.
So this is another important mechanism for cognitive decline.
Yeah.
Then
It's one of the first early signs of cognitive decline, which scares me because my sense of smell, I think, is going. But very quick test is smell.
Yeah. Yes. So smell is a very important factor. Then, and Eric, to make you feel better, I never had sense of smell.
Okay.
My wife makes fun of me. I very often cannot smell. And this has been there since my young
Good.
age. There's a problem. And so very, very rarely I just start smelling things all of a sudden, and then it turns off again.
Oh.
So so hopefully I am okay and you're okay.
Yes.
So the next theory is the natural killer cells. Natural killer cells are part of the innate arm. I call them pervert cells out of all the immune system cells. I call them pervert because their function is to touch every other cell. They cannot pass by without touching a cell. And when they touch a cell with their receptors, they are actually feeling the health of the cell. A healthy cell has a set of proteins on its surface. I always give this example, just like I have hair on my head. Imagine hair on the head is an indication of a healthy body. Imagine that's not the case. I mean, we go bald and we are healthy. But imagine for a second that the hair is a sign of health. So now somebody who sees me, if I don't have hair, they'll say he's not healthy. Or somebody who touches and sees I don't have hair, they would say this is not healthy. So similarly, NK cells are passing through the other near the other cells. They touch them and they see the cluster of designations, small protein clusters. Are they there or not? And are they in the correct density or not? If not, that means the cell may be sick by a virus or by cancer. Excuse me. And NK cell's response to that is to kill that cell. So their function is to clear out cancerous and infected, virally especially infected cells. Now, if NK cell number goes down, then viruses get a chance to increase in number because the infected cells are not cleared out efficiently. So NK cell depletion can also lead to damage to the tissue because viruses and more viruses than just the SARS-CoV-2, other viruses could get activated too. And now we have a problem as well. Interestingly, a few days ago, actually not a few days ago, 2 days ago, I did a discussion about the intermittent fasting and prolonged fasting and the effect on the NK cells and the immune system. So Eric, this is so amazing. And this is 2014's discussion. And then I believe the researchers got a Nobel Prize in 2016 for discovering autophagy. The discovery was this, that when we do phagocytosis, immune cells, sorry, I shouldn't say phagocytosis, when we do intermittent fasting or prolonged fasting, when we starve our body, then guess what happens? Every cell is sitting out there saying, please give me food, give me nutrients, give me oxygen, give me water, right? And you're not giving them nutrients, for example. Don't stop oxygen because we cannot tolerate that for more than a few minutes, right? And also don't stop water because kidneys would die. But let's say there is no food. Now the cell that is damaged, imagine it's a viral infected cell, virus infected cell, or it's a cancer cell, or it is some other damaged cell who had been in an immune war. Right. Or it is a cell with, let's say, the S1 protein hiding in it, or some other virus hiding in it. And now you have deprived the cell of nutrients. So one simple straight answer or concept is that when there are less nutrients, cell cannot function correctly, so it cannot take care of the problems and it would die. So intermittent fasting or prolonged fasting can cause those cells that are at risk to clear away because they need energy to stay in the game and they don't have it. And that energy is needed more by the cells that have viruses in them because they are overactive and they want to work and they want to make more viruses. And you cut their supply and they die. Or those cells that are damaged and these want to rebuild their systems. And for that, they need to pick up the energy to use it to make their systems. And if you don't give them energy, they're going to die as well. But here is the fun thing. Before a cell dies, Eric, this is such a fascinating mechanism. I can go hug the person, the researcher, for discovering it. Before the cell dies, what it does is, just like if we do not have food, what will we do? What will our body do? Our body would start looking inwards to say, is there something within me that I can use as food? So first of all, we'll attack our glucose and eat that up. Then we'll attack the glucose in the liver and eat that up. Muscles would attack their glucose in themselves and eat that up or use that. And then, of course, we'll attack the fats. Before muscle attack their glucose, we'll attack the fats and say, all right, can I get more nutrients out of the fat and convert them and use them? And at the end, we'll attack the proteins. We do not want to use our proteins as a food because muscles are going to take us away from the area where we don't have food to an area where we have food. So imagine if we used our proteins first, our muscle first, then we'll just be a lump of something which cannot move towards food. So this is what we do. Our cells at the microscopic level do the same thing.
Yeah.
So before they die, they look inwards and they say, do I have anything that I can break and eat? Can I break something within me into smaller nutrient structures like amino acids and then use them to do my essential functions? This process is called autophagy. And this actually starts. So there are a few enzymatic complexes which will become activated. It's such a beautiful thing. There is a complex called ULK, and there is a complex called Beckel, and there is another complex called ATG. So what happens is ULK complex becomes activated. That activates an ATG complex, which would then activate the formation of phagophores, or formation of little stomachs within the cell that are going to go and attack the cell's own parts and eat them. Now, when they try to attack these parts, imagine if there was a virus hiding in there, or there was a spike protein hiding in there. What's going to happen? That is, so imagine the S1 part of the spike protein is sitting inside the monocyte and saying, all right, you can't kill me. And we do intermittent fasting. All of a sudden, this cell is looking inward to eat something. And what is it going to try to eat? Everything, including that spike protein. Not only it would clear out the spike protein, there is another very interesting mechanism. And you work with the chronic diseases. This is such a beautiful immunology mechanism. My brain was like, it went boom. That mechanism is this. This monocyte that is holding on to the S1, it is sick with S1. It cannot present it anywhere. It is just carrying it, and it is in an inflammatory state now. Imagine if that monocyte starves a little bit and it starts trying to digest that spike protein. In that process, it can break it and it will present that on its surface, because that is a function of the cell to present antigens on the surface, correct?
Yes, yes.
Now, this was not presenting it on the surface. After intermittent fasting, it is presenting it on the surface. Okay. And all of a sudden, the remaining immune system will become active and say, what the heck is you gotten here? And they would not only clear that, but they would become sensitive to that part. In addition to this mechanism causes interleukin 15's release. Interleukin 15 is released when we have cancer cells sitting in our body. And there is a specific NK cell, or not, we shouldn't call it an NK cell. It's not an NK cell. It's not a cytotoxic cell. Eric, it is not part of adaptive or not innate arm. It's a new kind of a cell. It is called innate-like T cell. And it is called innate-like because it works like an innate cell. It does not need any other cell to sensitize it to something. It can look at an enemy and attack. That is innate cell behavior. But it has T cell receptors on it. So it has a T cell behavior, right? Yes. And so that's a beautiful cell. And that cell has another behavior. Most of the cytotoxic cells, for example, natural killer cells or CD8 positive cells, their function is to look at abnormal proteins on the cell surfaces or abnormal clusters and then kill those cells. This cell, innate-like T cell, can attack a cell that has abnormal or normal proteins, and it can detect if they're sick, and it can kill them. Now, interleukin 15's release improves this NK cell's function. So the whole thing comes together. And one final mechanism, After that, I'll stop from the mechanisms. And that final mechanism is B cells, memory cell. So when there is, let's say, SARS-CoV-2 in our body, we will make B cells, we will activate T cells, and they would attack the virus and virally infected cells, and we'll do all that. In that process, we'll make memory cells as well. The memory cells, we know, would live at the site of infection. They would live in the local lymph nodes at the site of infection. This is why you'll see swelling of the neck or jaw, under the jaw, after the vaccine or the infection. And then they can circulate in the blood for months and years. And then they can also go to bone marrow.
Yes.
They don't always go to the bone marrow, but if they go to the bone marrow, they would live there for decades. That means we might have immunity in some cases in some people for decades. But there is a problem. If those B cells that have gone to the bone marrow, if they are active there, then what would they do? They would release inflammatory markers, which will activate the other cells in the bone marrow. So imagine you put a bomb in a ammunition depot. That bomb, if it goes off, it's going to blow up the whole ammunition depot. So bone marrow is an ammunition depot. We are making new immune system cells there. So what happens is, if this B cells become active there, it can cause other cells to become active. And one very special cell becomes active and can bother us and create long COVID. That is a cell with mono or cell with EBV in it, EBV genes. So when we get mono, you know it better than me. You work with the chronic diseases too.
Yep.
When we get mono, we get the B cell, which is a memory B cell, which has genes of the EBV, and that goes and lives in the bone marrow. And over there, it relapses and it becomes activated every so often. This SARS-CoV-2 memory B cell, when it goes to the bone marrow, it would cause, if it causes local inflammation, it can activate those cells with EBV genes in them. And all of a sudden, EBV relapse would occur. And now the patient would start having for months EBV symptoms, and they can even become positive. An interesting thing is this. You know, Eric, that EBV has a cyclic behavior, and you can start predicting when it's going to go away a couple of months later or something, right? If the EBV is being triggered by this SARS-CoV-2 caused memory B cells, then there is no guarantee that that EBV cell would calm down after 2 months.
Yeah. Yeah, I mean, that is the problem, is that the herpes family viruses, the EBV, the HH6, the CMV, they immortalize themselves in our B cells, and if we don't control them, obviously they've co-evolved with us, so they probably give us some benefit along the way, but we have to keep them under control. It's all about control, and this is, I mean, I just love this fascinating. You know, it helps of how the intricacies of immune function. I think that's just so important. I know it's often too much for you know, patients, but I just want them to understand that there's a balancing act, and there's rarely a perfect answer, but it's just about getting a complex system back to a sense of balance. And that's what we're trying to do. And as one other little thing, the thing to notice is that when you fast, you deprive your body of sugars, okay? And glucose is what 6 cells need for energy. That's the reason that I think a lot of people with chronic illness actually crave carbohydrates and sugar, because their mitochondria they're not broken, but they're in a protective mode when they're not making ATP as much. So you have to burn glucose for sugar, for energy. And when you fast, that quickly goes away, and that stresses those cells that are already ill, which kind of fits into this whole, just a fascinating process of how. So I mean, so the upshot of this is that there is a thought that perhaps fasting may in fact help people with long COVID. Has there been a study, or is
Right.
it just a supposition?
So this is at this time a supposition. However, my anecdotal, I'll tell you a story within my own family. So a member of my family became vaccine injured and then stayed on for 6, 7, 8 months. And then she recovered after we used the medicines that I thought we should. In that process, early on when she had these symptoms, one day I asked her, "Hey, do you want to go out for lunch?" And she said, "No, I'm fasting." And I said, "Why are you fasting?" And she said, "It makes me feel better with my symptoms." Right? So every time she'll get a flare up, she'll start fasting without knowing what mechanism may be happening inside. So I have seen many patients who, when they have a flare up, they start reducing their food intake without knowing what is the mechanism happening. They just kind of feel better with the less food they eat. So there is no study yet.
Okay, but it's definitely a fascinating topic. You know, we can. I realize we were supposed to. We of course. I love the fact that you don't pay much attention to time either, which is good. Um, so, but
My apologies.
no. It's wonderful. Time is just a construct, I always say. But I would like to just go, if we could, you know, before we wrap up today, if you could talk a little bit about Dr. Pretorius's thoughts on the clotting mechanisms, because that again, like I say, I think each one of these is a window into
Yeah.
the body's processes. Oh, and one other point that I think I'd like to we'll probably talk another time about is I think Dr. Patterson's test, the Incel DX test, I have found to be very, I mean, I've looked at cytokine panels over the years, and I've usually found them not very helpful. I'm finding his very useful for all kinds of chronic illnesses.
Yeah.
And so
So
maybe
the
we'll talk more about that next time, or our third will go into depth, because I think it's a very useful construct. But I'd love to hear your thoughts about Dr. Pretorius and the clotting aspect of how much that
yeah.
may be contributing.
Yeah, so I have her. It would be great to actually see her those cells. But anyways,
Oh, you
her
can
basic.
share your screen if you would like. That's
Yeah,
perfectly.
yeah. So if we can, let me just very quickly make sure. Um, so if I share my screen,
Do I need to give you permission for such a thing, or I hope not?
I
You'll just share.
let's see. I think I have it here.
Yeah. Oh, there
So
you go. Perfect.
so let me know if you can see my screen.
Yes.
So this is her site, and this is the long COVID. So if you see these cells, I hope I can kind of zoom into them and show. Um, okay, so I thought this would open up the cells itself.
Oh,
So
well, yeah, here we go.
yeah, so I just increased it this way. So if you see here, her theory is that normally this set of fibrin are not present. These strands are usually not present. And then the cells are mostly pristine and clean and clear. Just like if we have plates in our kitchen, they are usually clean and neat.
Yeah.
You don't have dust sitting on them and threads or stuff like that. So her theory is that in COVID, the as the clotting system becomes dysregulated, the fibrin strands start connecting cells with each other. And these, do you see here, the RBCs are connected with this junk on them, which she believes that this junk is not normal and this should not happen. Similarly, if you see here, this is another cell where this little
Connection. Yeah.
fibrin strands are attached, or this here, these fibrin strands are attached. So, and this is a little zoomed out view where these are the whole network of fibrin strands is stuck here. And she's saying that as these fibrin strands are activated and the clotting is activated, they are making more clots and they are causing almost all cells to have this kind of issues. And so her solution to this is to do electrophoresis and clear the blood off of these. So that is her, I mean, in a nutshell. Let's do this and we'll go in a more detail for how this happens next time as well, just for
Yeah.
the time's sake. But this is her work, and I
Yeah.
love it.
Yeah, I'm very interested because we there's people who I've worked with who look at what we call live blood under the microscope, something that's
Yeah.
never made it into the conventional medical world. But
Yeah.
when you look at people who have illness, chronic illness, you almost always see a lot of rouleau formation, which is the red blood cells kind of sticking together and stacking on each other, and
Correct.
a lot of
Correct.
fibrin. But we'll talk. I said next time we'll go more into her work, which I think she's describing that the fibrin sheets are actually changing molecularly a bit, and which is
Yeah.
really interesting as far as understanding perhaps even other chronic infections effects on
Correct.
cognitive
Correct.
function. I think could
Correct.
be interesting. So
And rouleau formation is one important test as well for chronic diseases.
yes, yes. So, I was I said just before we end, someone asked in the beginning about Lyme, and what I was I'm gonna have to say is that at this point, I have to myself have to do a little more deep dive into what other people are writing. I can only tell you that if you have Lyme disease that sticks around, you're going to have immune dysfunction. Lyme, like many bugs that stay in our body, in order to survive, they communicate and change our immune system a bit. And so you're going to have troubles. Whether you're going to have, what I haven't seen, thankfully, is an increase in, well, I shouldn't say an increase. I haven't seen, I think the hardest thing people have to understand is that when you're doing clinical medicine, we don't have good denominators. Okay, so it's really hard to say there's an increase or a decrease. We're looking at, small numbers of patients, and it's scary. One of these academics said something to me that I hated. The plural of anecdote is not data. and we have to remember that, in my small experience, I can say that I haven't seen a lot of my Lyme patients or my chronic Lyme patients necessarily have more long COVID or vaccine reactions than other people. But I don't have a big enough numbers to really know that that's meaningful. And it's you would think in this day and age that someday we would have a database that we could actually get real data, but we're still in the Stone Age. Of clinical medicine.
Especially with and on top of that, we have a new disease for which we need to learn a lot. So we were thrown back to the Stone Age of the Stone Ages because of this disease.
Yeah. No, it really is a shame. It's a great example of, I myself don't want to be tied to socialized medicine, but I have to say, England has at least given us a lot of good data.
They have given us great data.
Yeah.
I'm not impressed with their management of COVID, but the data, man, they have given.
Well, I mean,
Israel and England. Yes.
Yes.
Israel and England have both given us great data.
Yeah, well, someday one of these days we'll have a discussion about how to improve medicine. That will be an interesting one. Unfortunately, I don't think anyone will listen, but we can keep hoping. So I want to again thank you so much for your time. And I mean, Barris, I don't remember our next date. It's in a few. Do you happen to have that in front of you? I should. It's very. But it's in a few weeks. We'll have our next episode where we'll talk a little bit more about etiology of long COVID and the biochemistry and how it's affecting individual organs. Because I think the more people understand, it will because
absolutely
you have to be your own doctor. Unfortunately, I wish it wasn't so. You always have to find doctors to help you, but I find my patients do best are ones who are aggressive and think and do the reading and because this illness is about your body. It's not something that we have off-the-shelf treatments for that are going to work all the time. Some of them will, but you have to do the work, unfortunately. So again, Dr. Syed, thank you so much for your time and expertise, and I look forward to talking with you again soon.
Thank you very much, Dr. Gordon, for having me. I look forward to having more of these discussions. I love them.
Wonderful. Blessings, and really stay well and help keep your family healthy.